Hi everyone, we're just letting the everyone join, so just bear with us for a few moments whilst we get everybody online. That's looking good. Thanks ever so much for joining us this afternoon for me and morning for lots of you around the world. I will get started whilst people are still joining. Thank you again for being part of our webinar this afternoon. We're very excited to have such an esteemed panel. We want to thank really INL, the US State Department, who helped make the suggestion and are moderating with Charlotte. So thank you very much for bringing us all together, and to our colleagues at UNODC and WHO for putting in touch with the right speakers and helping us build an excellent webinar today. Just very quickly, I think a lot of you know who ISSUP is, but we are a membership organisation for anybody working in the drug demand reduction field. So that's within prevention, treatment and recovery support. We want to bring that workforce together, help you connect with each other, help you learn and get the relevant information to the fantastic jobs that you are all doing. Today's webinar will be uploaded to the ISSUP website, so there will be a recording that you can access. So you can go and check in the next couple of days and pass that to your colleagues if people have missed it or if you have any problems. Do forgive us if there are technology problems. We're all connecting from around the world, so we hope that the technology will be with us today, but we can never rule out there being some problems. We are delighted today to have interpretation in 5 languages, and information about how to receive the interpretation will be posted in the chat. You can already go and see that. We have interpretation in Spanish, French, Russian, Arabic and Urdu. We have a slight problem with, we're hoping to just working rapidly with the interpreter into Urdu now, so we really hope that that will be there. But please do follow the links and open the Interactio app and you can get the interpretation there. Everybody who is attending today will receive a certificate after the event. So that's a certificate of attendance, so look out for that. And we will be taking your questions. So if you could pop any questions that you have in the questions section, then we will be collating those and answering them at the end. And if there are any that we haven't had the time to get to, we will pop a link on where those questions will be answered. So you can, pop those there and we'll be looking at them throughout and collating throughout the webinar. So now all I have to do is hand over to Charlotte. Thank you again for moderating this session for us, Charlotte, and have an excellent session.
Great, thank you so much. Good morning, good afternoon, and of course, good evening to everybody watching today's webinar. I would like to start by thanking the International Society of Substance Use Professionals, ISSUP, and the United Nations Office on Drugs and Crime, UNODC, the World Health Organization, as well as to all of our presenters for collaborating on today's webinar in honor of International Overdose Awareness Day. International organizations play an important role in connecting drug use prevention and treatment practitioners with researchers, academia, policymakers, and others stakeholders to promote best practices worldwide. Today is no different, as ISSUP, UNODC, and WHO have brought together an amazing group of experts from around the world to talk about the life-saving overdose reversal drug naloxone and how it can be used to save lives and improve outcomes for people with opioid dependence. Before I moderate today's webinar, I would like to say a few words about the work that the U.S. Department of State supports for drug prevention and treatment programming globally through the Bureau of International Narcotics and Law Enforcement Affairs, or INL. We have 3 strategic components to our work. We want to promote the adoption of recovery-oriented, evidence-based drug policies and internationally recognized standards, establish continuous drug data collection, and conduct systems analysis to focus attention on specific requirements to assure the quality of drug treatment services, and finally, to implement programs that effectively prevent and reduce drug use disorders. To do this, our work centers on supporting training for professionals in the field of prevention, treatment, and recovery through free curriculum that has been developed by international experts. And all of that free curriculum is available through the ISSUP website, to include 2 new self-guided courses. We also support the credentialing of professionals in the field of substance use disorders. Over the past year, we've been working with our partners to move much of our training to online platforms to widen the access to evidence-based practices. We recognize that substance use disorders are a major public health threat and that they are preventable and treatable. We also believe that we can make progress by focusing on evidence-based approaches that work. The United States has been pleased to support the United Nations Office on Drugs and Crimes work to create the international standards for the treatment of drug use disorders. Through these standards, an integrated system of evidence-based practices are provided to patients in a comprehensive array of mental health and addiction treatment services, from early interventions, outpatient services, to residential and inpatient services, to medically managed intensive inpatient services based on a client's unique recovery needs. One of the most important components of this system is the entry point, the point at which a person in crisis is first able to interact with care, infrastructure, and get connected to services that can facilitate their recovery. In countries all over the world, and especially during the recent pandemic, we are seeing increases in opioid overdoses that often tragically result in death. Amidst these tragedies, the bright spot has been the vast increase in the use of telehealth services and greater access to treatment programs than before the pandemic. We've also seen the rise in opioid overdoses has led to greater public awareness of naloxone and to the power it has to reverse an opioid overdose. Someone experiencing an overdose is in dire need of assistance, and if administered naloxone properly, it can save their life. It can also be an entry point to recovery services. To that end, we want to ensure that opioid reversal medicines are available not only to medical practitioners and first responders, but also that need access to them through friends and families in our communities. We also want to make sure that people likely to witness an overdose are well trained and aware of medical and recovery resources in the community. For the past several years, the United States has supported the joint efforts of UNODC and WHO within the framework of the UNODC WHO program on drug dependence treatment and care on the development of a pilot program called the Stop Overdose Safely Initiative to provide naloxone kits and training to people likely to witness an overdose to a wide array of people, regardless of their previous health training. I want to commend UNODC and WHO for their work and dedication to this program that shows it is feasible to provide naloxone to people in the community likely to witness an opioid overdose, in combination with training on the use of naloxone and the resuscitation of people experiencing opioid overdose and to save lives. Just last week, President Biden proclaimed this week as Overdose Awareness Week, calling upon citizens, government agencies, organizations, healthcare providers, and research institutions to raise awareness of substance use disorders, to combat stigma, to promote treatment and celebrate recovery, and to strengthen our collective efforts to prevent overdose deaths. In September, starting tomorrow, for the entire month, and the United States celebrates alcohol and drug addiction recovery. And I think it is appropriate that today's Overdose Awareness Day leads straight into Recovery Month. As we hear about the amazing results of this program, let's keep in mind that each life saved by the reversal of an overdose with naloxone is a chance for someone to get connected to the services they need along their recovery journey. So now it is my pleasure to start the webinar and to introduce our first presenters, UNODC Anja Busse and WHO Dzmitry Krupchanka, who will present on the Stop Overdose Safely model. I'd like to give a quick introduction that Dr. Krupchanka is a medical officer with the Management of Substance Abuse, Department of Mental Health and Substance Abuse at the World Health Organization based in Geneva. He has also worked as a senior researcher at the Department of Social Psychiatry, National Institute of Mental Health in the Czech Republic. Anja Busse is a program officer at the Prevention, Treatment, and Rehabilitation section of the UNODC Drug Prevention and Health Branch and has been involved since 2005 in the implementation of UNODC's Global Project on Drug Dependence Treatment and Care in Different Functions. She has a psychology degree from the University of Berlin in Germany, as well as additional training in public health and systematic psychotherapy. I would now like to turn over the floor to both Dr. Krupchanka and Anja Busse. Thank you.
Thank you very much, Charlotte. And maybe we will also start our joint presentation by really thanking everybody on this panel who have been involved not only in the development of the webinar today, but you all have played a role in either the development or the dissemination of the Stop Overdose Safely initiative. So thanks in this regard to everybody on the panel, but I also would like to start thanking really the amazing audience. We see we are way over 300 people for your kind of commitment and dedication to the topic of stopping overdose safely, and for commemorating today with all of us International Overdose Awareness Day. So thanks for that, and a special thanks if some of you who are joining us have maybe been at country level or in other functions, also directly been involved in the implementation of the SOS study or initiative. So as said, we will do the presentation together. Next slide. And I think Charlotte already mentioned in her introduction how the work that UNODC and WHO are doing around overdose prevention and emergency management of opioid overdose is embedded in our joint program on drug dependence treatment and care, which is a true interagency program. We're working together at country level. We're working together on the development of technical tools, really with this idea of a one UN behind us, and supported by the UN member states that also have given us a mandate and encourage us repeatedly to work together. And one of the major outcomes of the UNODC WHO program are the international standards for the treatment of drug use disorders, which hopefully many of you that are attending today have already seen. They were launched in 2020, and with a view to our topic, opioid overdose prevention and management is kind of clearly embedded in the continuum of care that we are describing in the international standards for the treatment of drug use disorders. And the standards are also gradually becoming available in more languages. Next slide. With a view to the data on overdose, World Drug Report 2021 just stated that in the year 2019, there were 62 million people who have used opioids for non-medical purposes, which corresponds roughly to 1.2% of the global, let's say, adult population, or the population between 15 to 64 years, with regional differences. And according to WHO estimates, around 500,000 deaths that can be attributed to drug use every year. And in the year 2017, there were 115,000 people who have died of an opioid overdose. Next slide. This graphic is also from World Drug Report 2021, and kind of it shows over the last decade a sharp increase in drug-related deaths, with breaking it down here into deaths related to drug use disorders directly or indirectly. And deaths related to drug use disorders directly are mainly overdoses. And this is also the area where over the last decade we have seen the sharpest increase by 45%, so that the estimate for the year 2019 were 128,000 overdoses. And in total, so to say, it came to the nearly 500,000 that I just mentioned before. Next slide. Kind of with this situation already evolving, in 2012 already member states in the Commission on Narcotic Drugs have passed a resolution on promoting measures to prevent drug overdose, in particular opioid overdose. And member states were encouraged to include effective elements for prevention and treatment of drug overdose in their national drug policies, and have requested UNODC in collaboration with the World Health Organization to include initiatives that prevent mortality from drug overdose and opioid overdose in our drug demand reduction programming. And with this mandate in the back we have started working increasingly on the topic. Next slide. And then in the following year, UNODC and WHO jointly presented the discussion paper on preventing and reducing opioid overdose mortality. And we discussed a number of effective measures, including, of course, access to effective evidence-based treatment for people with opioid dependence, increased availability of drug treatment in prison settings, and the effective treatment or effective interventions for opioid overdose. One of the things that was discussed here was also that while naloxone kind of has been traditionally used as a medicine by medical staff to manage opioid overdoses, new approaches were emerging that included the distribution and training of other first responders on effective overdose management, including with naloxone, and not only to professional first responders like police and firemen, but also to other people that are likely present when an overdose occurs, like people using drugs, peers, and family and community members. Next slide. In 2014 then, in the following year, WHO actually issued the guidelines on community management of opioid overdose, which are based on an evidence review and expert consultations, and some of the experts are also today here with us on the panel. And the WHO guidelines basically have 4 recommendations, and the first one picked up kind of this idea from the discussion paper just mentioned before, that all people likely to witness an overdose should have access to naloxone and be instructed in its administration so that they can use it in cases of suspected opioid overdoses. And the other 3 recommendations are that different formulations of naloxone are effective, and it depends on the skills of the person, but also the local context, which formulation to be used. And third recommendation to also focus on airway management, assisted ventilation, and then the administration of naloxone. And the 4th recommendation basically to not leave people alone after a successful resuscitation with naloxone, but to stay with them and observe if full recovery from the overdose could be achieved. So these kind of guidelines by WHO then really set the ground for further interventions based on evidence. Next slide. And 2016 was a very important year for international drug control, all work on prevention and treatment of drug use, because the General Assembly of the United Nations came together in New York to meet on the world drug problem. That's something that doesn't happen very often, more or less every 10 years maybe. Therefore, it was really a major event. And as part of the outcome document of UNGAS 2016, in the operational paragraph, there is this recommendation, again, to include overdose prevention and treatment in national drug policies and national legislations, but also kind of to make elements of prevention and treatment available, including naloxone, to reduce drug-related mortality. And I think it's something really worthwhile to be noted that a medication such as naloxone has been recommended and has been noted at this very, very high level document, where all member states of the world, or all UN member states, and therefore nearly all countries in the world, have come together and passed this recommendation. Next slide. And then in the following year, we launched the SOS initiative, which we are happily presenting to you today, including their results. And the SOS initiative, first and foremost, is also a platform for exchange and for mutually kind of finding ways to promote effective implementation of overdose prevention programs. And all of this under a common goal, which we have set here as a 90-90-90 goal. And with the first 90% being that 90% of all people likely to witness an overdose should be trained in effective emergency management, and that 90% of those trained should be supplied with actual naloxone, and that 90% that have been supplied with naloxone also carry the naloxone. So, and the SOS initiative really also at the end, and if you're interested, I encourage you already now to reach out to us, because we really hope that this can be an encompassing and inclusive initiative where all of you that are joining us today in one way or the other can join in. Thank you. Next slide. And here I will hand over to Dzmitry, who will kind of start explaining how the SOS initiative, which is this platform, we have really managed to turn into a concrete project and demonstrate community management of opioid overdose in 4 countries, thanks to the support of the US State Department, INL. Dzmitry, over to you.
Thank you, Anja, and thank you, organizers and INL and ISSUP for inviting us and for hosting this webinar. And I'm excited to see almost 400 substance use professionals or some other participants here. So, you know, I can imagine that if we were in a real audience, then there were many of you, especially today for this International Overdose Awareness Day, I think many of you are aware that this is an important topic and that, as Anja presented, there is a good policy framework, there are guidelines, the understanding of the burden. But what's still unclear is how to make these changes implemented in the communities on the ground. And that's why, as Anja said, we decided to do the implementation part of SOS initiative. The selected 4 countries with high prevalence of opioid overdose, which were Kyrgyzstan, Kazakhstan, Tajikistan, and Ukraine. And the project started in 2016, so it's been 5 long years with a lot of work behind. So there were at least 4 stages for the implementation of the study, and it's included the assessment phase, when the WHO and UNODC approached national governments, asking them to assign focal points, and then we organized a stakeholders meeting in each of the countries, and slowly we're developing protocol and adapting protocol to the local circumstances, to local national context, basically developing it together with national counterparts, and also identifying not only policymakers that can help to make this project work, but also professionals, substance use professionals, and different NGOs working in the field, working in harm reduction services, in healthcare facilities, that can make this project more successful. Then the detailed situation analysis was done in each country, which included legal reviews, because it was important to understand what are potential harms or risks for people carrying naloxone. Based on all this work, the study protocol was revised once again. We obtained ethical approval in each participating country, and also by WHO Ethic Review Committee. Then the quite comprehensive training materials were developed with 4 different modules for cascade training, and then they were also tested in focus groups and then used to train national master trainers, and these master trainers then transmitted this knowledge further to potential witnesses of opioid overdose. And then basically in somewhere in 2019 to 2020, we started actual implementation parts of the study, when training was rolled out to as many potential witnesses as possible. And then it's like a dissemination of naloxone kits started. And then also we were collecting data within the cohort study, results of which will be presented later by Professor Dietze. And kind of now we at the final stage of evaluation and dissemination. Basically the data analysis has been done, the report of this study has been published jointly by WHO and UNODC, and now we're working on additional papers that will come soon. And today we're disseminating to you results showing the feasibility of work on community management of opioid overdose. Just to show you a couple of pictures to bring a life to what has been done, and to acknowledge many people who participated and make this project work. Like Professor John Strang was one of them, then my colleague Dr. Nicholas Clark, Joanna Busse, and many also national counterparts from these 4 countries. So for example, this was a meeting in 2016 when the study protocol was developed. Then we had a meeting where all the detailed element of study implementation were properly planned in a theory of change exercise with country focal points. And then in 2018, we did a training using the logic of cascade training, as I said, and 4 modules of training materials. So the training was looked like was done in 3 levels, when the training provider prepared master trainers that then disseminated knowledge at country level to trainers, and those trainers to potential to people likely to witness an opioid overdose. And in the end, this cascade training resulted in about 14,000 people trained in these 4 countries. And this 14,000 people trained, they were also supplied with the naloxone kits, which were developed jointly also with national counterparts, and so also tested in focus groups to see if they really if it's convenient to carry with them, whether people can carry these kits with them, and that they can be used in the case of overdose events. And then further details will be presented, like study results by Professor Dietze, but as I said, you can find the publicly available summary reports of this project, and also it will be translated in different languages, but also soon there will be additional papers coming, one including detailed qualitative feedback from project participants, and also a paper with more details on the impact of the SOS project. Now, we see that it's feasible and it's possible to make overdose prevention work at a community level, but it would be nice to scale it up, because in this project, it wasn't a nationwide project. As you see, like 14,000 people, it's about like a couple of thousands per country. But if to scale up to the whole country, then many more lives would be saved. And then, of course, these materials can be used for further advocacy and rising awareness about overdose, showing that it's feasible to implement projects like this. And we will try to move SOS initiative to other countries and to use it as a tool for global partnership, advocacy, for strengthening programs on overdose prevention and management. And I would like to end up on a movie that was recently developed based on our experience of implementing SOS project in these countries. And I kindly ask organizers to start this short video.
This is a film about life, about hope, of actions that make a difference, and it's about our future. It's also a story about people who help change lives, people who help save lives, and it's also about remembering, not forgetting. Remember the 500,000 mothers, fathers, sons and daughters who lose their lives to drug use every year.
It's not something that Jonathan did or didn't do. He was the son that any mother would have wanted her son to grow up to be. Unfortunately, we still don't know what makes someone vulnerable to develop addiction. He deserved to live a life like any of us. He would have been the kind of person that you would have interacted with in your daily basis and would not have thought twice that he had a problem, that he had this terrible, terrible disease. That's why his death was such a shock for our community, because he was a good person. He deserves a legacy, and I will make sure that he has that.
Each year, at least 115,000 people die from an opioid overdose. But we have the chance to reduce that figure. We have the chance to make a difference. And effective solutions already exist, most of which operate at the community level.
It doesn't just change an individual when you treat somebody with drug use. It changes a family, it changes a community. We have a team of outreach workers who go out to the community and identify these persons who have the need for methadone maintenance therapy, psychosocial support, and other interventions as per the assessment of their needs. Psychosocial intervention is quite a wide range, ranging from psychological services, social skills improvement, family integration, people who come when they are unkempt, they are dirty, they are homeless, they are malnourished, they come back and they restore their human dignity. It gives you job satisfaction because you go to work and you know you're going to change somebody's life.
This success story in Kenya is one of many community-based programs that is a cost-effective and high-impact solution. But there are many more successful initiatives happening all over the world.
Люди, когда приходят к нам, они привыкли к тому, что им никто не хочет помочь. И когда они видят принятие, поддержку и конкретную помощь здесь и сейчас, это очень подбадривает. Мы обучаем людей о том, что такое передозировка, то есть рассказываем, какие они бывают, какие симптомы и как можно помочь человеку, если вы увидели передозировку, если стали свидетелем передозировки.
Тоже рассказываю про naloxone, чтобы он был в доступе, как им пользоваться и чтобы избежать смертельных передозировок.
Наркозависимые люди, когда чувствуют принятие и поддержку, они готовы меняться сами и отдавать обществу тоже только хорошее.
People are helping people. Never has collaboration been more important. Ideas that have been approved at the highest level are working at local levels.
The SOS project, Stop Overdose Safely, is a really wonderful project. Within the project, we provided services to more than 5,000 people. We provided them with kits with naloxone and with unique training. We trained 5 master trainers and 54 national trainers who provided training to people who live with people who are under utmost risk of suffering from overdose. Without the support from WHO and UNODC, this project would be impossible.
Right now, we have an opportunity to realize that we can scale up overdose prevention activities. Today we can act to make a difference. Today we can help to break the stigma. Today we can stop thousands of unnecessary deaths. Drug dependence is not a choice. It never has been. It's a complex mental health condition and not a self-acquired bad habit. It can be prevented and properly addressed to improve life and well-being of people. It should be an integral part of primary health care and universal health coverage. Today, we invest. Tomorrow, we move forward.
So I think that this movie transfers emotions much better than our presentation. And I hope that you could feel the spirit of the project implementation. And we are very grateful to all partners and all people who made it possible, and to INL and to Burnet Institute And in the next presentation, I think you will see more details on the actual results of the implementation. Thank you.
Great, thank you so much, Anja and Dzmitry. That video was certainly powerful, and you have done an amazing job. Really hard work over the last 5 years that you heard. If anybody has questions for Anja and Dzmitry, please, just a reminder to anybody that has questions throughout this webinar to enter that into the chat box so that we can address those at the end and take questions, because I think I will have some time for questions at the end. Next, I would like to introduce Professor Paul Dietze, who is the Program Director of Behaviors and Health Risks at the Burnet Institute in Australia. Professor Dietze is one of Australia's leading alcohol and other drug epidemiologists and has more than 20 years experience in the field of alcohol and drug use related harms. He was a member of the Guidelines Development Group on the Management of Opioid Overdose for the World Health Organization, and has also been involved in the development and implementation of a variety of heroin overdose prevention initiatives involving intranasal naloxone, published over 160 articles, and has received numerous awards and prizes in recognition of his work. And we're so happy to have you here and your expertise for this webinar today to present the findings from the SOS study. Thank you. I'll turn it over to you.
Great. Thanks very much for the wonderful introduction. It's great to be able to present some of the findings from the SOS project that Dzmitry and Anja have spoken about. It's been a privilege to be able to work on the fantastic project across these 4 countries. I'm speaking to you from Melbourne, Australia. It's quite late at night here now, and it is International Overdose Awareness Day. I want to give a quick shout out to my dear friend Sally Finn, who actually started the whole idea of International Overdose Awareness Day some 20 years ago or so. And it's also worth pointing out, I guess, as Professor Strang, who's speaking later, might suggest that the idea of take-home naloxone really started or was first voiced at a conference here in Melbourne in 1992. So it's taken us quite a while to get to the point of being able to kind of talk of widespread implementation of this initiative or of this type of program, but we are getting there. Before I begin, just a couple of disclosures. So I've received some investigator-driven funding for hepatitis C treatment work that really doesn't have any relationship to this presentation at all, but I have received some work from Indivior related to buprenorphine naloxone, again, not really related to this work. And I have been involved in some intranasal naloxone work, as was mentioned, but haven't received any payment for that in the past. So we've heard about the way in which the SOS, or Stop Overdose Safely initiative, developed. And we've heard about the project, the 4-site, multi-site study, implementation study that was run between 2016 to 2020. And what I'll be talking to you today is about evaluation of whether or not the project achieved its aims. And the aim is listed there on the slide. So it's really to look at the feasibility and impact of community management of opioid overdose, including the use of naloxone in the countries, and the implementation of take-home naloxone with a focus on people likely to witness an overdose. And you can see the naloxone, a picture of the naloxone kits that Dzmitry showed you before. And just referring to the slide that he showed you before as well, I'll be talking about the evaluation phase. So some of the data analyses that we've done and the development of the reports that have been put out, and some of our dissemination activities, one of which is obviously presented here today. So in terms of monitoring and evaluation, we were looking at 2 main questions. So the feasibility of take-home naloxone and training on overdose management in the 4 countries, and the effectiveness of providing training to better respond to overdose. And the methodology involved a process evaluation. We've seen a few figures from that process evaluation in Dzmitry's presentation. We also did a lot of focus groups with people who are involved in the program, and I'll talk about them in a little bit of detail. Some key informant interviews, And we did collect a lot of training data, but I won't be talking about those today. And finally, an observational cohort study, which is the key role that I played in this work. So moving straight on to implementation, we've heard a little bit in the video and also in Dzmitry's presentation about the way in which the program was implemented, and the number of trainers who are trained is listed in this table. So varying across the different countries, but overall 200 people were trained to train people in take-home naloxone. Around about 14,000 witnesses were trained, or potential witnesses, sorry, that is. Most of them were males, but there was a good proportion of females too. And you can see we really did get a lot of people who were kind of connected to the drug markets. So people who consumed opioids themselves, a few family members, health workers. In the end, we distributed some 16,000 kits, and another 1,300 refill kits were requested. And those 16,000 kits, you should remember, each one of them has 2 ampules of naloxone inside. So in actual fact, 32,000 ampules of naloxone were distributed. So on to some of the key findings from the evaluation. In terms of the qualitative findings, so we undertook, as I said, focus groups and key informant interviews. And really, the main focus of that work was to look at what sort of skills people were picking up and their knowledge of how to respond to overdose, and also their use of the kits and whether or not they thought the kits were appropriate and effective, how the SOS program and participation in the training impacted on their lives, any barriers and enablers of implementation that they noticed, and then some future ideas and recommendations that they made. You can see that we conducted some focus groups before the intervention was undertaken, but the main focus of the work that we did was on focus groups done immediately after the intervention and a little way after the intervention, so some 3 to 5 months. And then we did individual interviews around about the time that around about the same kind of timing there. We actually interviewed and conducted a lot of focus groups, and you can see we had a large number of participants right across the 4 countries involved. And some of the key findings were that people felt really empowered, and they felt that naloxone really gives them a miraculous power to be able to respond to overdose in a way that they haven't been in the past. And the SOS program itself was providing them with the skills to administer it. The whole program worked to dispel myths, and it provided them the skills, as I said, to help people revive victims of overdose. It also brought out some feelings for people about the lives that could have been saved had this been implemented earlier, and also their experiences in providing training to other people. So the training didn't just impact on them, they were able to facilitate training around overdose and overdose response to their immediate networks as well. And they felt a sense of worth as a part of participating. I won't read out all of the quotes there, except maybe the one there in green for interpretation. This is a very important project because many young guys have already died of overdose and nobody in the community was aware of how to prevent it. And that was someone from Tajikistan. And you can see this is really empowering people to be able to respond. For people who use drugs, there was added benefits of them recognising and being more concerned about their own health and empowering them to be able to take control. We found some evidence in the focus groups about people injecting alone less, realising that that's a key risk factor for overdose, using drugs less frequently, checking drug quality before injecting, and also making sure that someone else around them has naloxone when they're using drugs, so that if something does go wrong, that someone is able to respond. And some people even spoke about stopping drug use altogether. And there was also some evidence of greater trust in healthcare providers. So people felt that there was no judgment from the SOS program implementers. They felt that they would be more likely to call an ambulance. They recognised that more services were stocking naloxone, which implies a sign of respect and care. And also, there was also some evidence of more drug treatment and antiretroviral therapy referrals. And some people reported about more trust in some police, and some police did actively get involved in the SOS project implementation. So again, just for interpretation, in green again, after an overdose happened, I quitted drugs. I wanted to live. The researcher advised to join OST program. Now I do not use drugs. If all this happened earlier, I would not have been in prison for more than 3 sentences. And that was someone from Kazakhstan. And then again, this narrative of care was something that was emerging. So people reported about now someone cares about the people who use drugs. So there was a notion that there was increased acceptance and positive community views about people who use and inject drugs. And people who were in that situation felt more valued and important. And then families were now comforted that there was people caring about their child or loved ones, or you know, in the past where they mightn't have felt that. And families had a greater understanding of the issues faced by people who use drugs. So to read again for interpretation, in the blue there, we see, although we are drug addicts, we are still human beings, aren't we? I used to think that everyone was just waiting for us all to die. Who needs these addicts? But the program shows no. Someone needs us, cares about how to save my life. For the first time I felt this. I felt respected, thanks to your wonderful program. That was someone from Ukraine. And these findings are really, I think, powerful, but also really consistent with lots of other programs around the world where take-home naloxone has been implemented as an overdose response strategy. And we found exactly the same things here in Australia when the program was first rolled out in the Australian Capital Territory in 2012. So now I want to talk about the impact of the study, and we measured this through a prospective cohort study. And referring to the 90% targets that were mentioned before by Anja, we really wanted to know whether or not 90% of people who are trained to use naloxone by the SOS project and the SOS protocols, whether or not they use that naloxone overdoses that they witnessed. And this is a summary of the design. So basically, we recruited and consented people into the study. We collected a lot of baseline information, including ways in which we'd be able to locate them for follow-up interviews and so on, and some basic scales on their knowledge of overdose response and also their attitudes towards overdose response. We then provided training in naloxone distribution, and then we again collected some information from people directly after training, trying to see whether or not the training actually improved knowledge. I won't talk about those data today, but rest assured that the training did work to improve knowledge. And then at 6 months, because we had contact details for people, we were able to follow them up. And we asked them about the number of overdoses they witnessed, whether or not they'd experienced any overdoses, whether or not they'd reversed any, whether they carried naloxone with them, and a few other details along those lines. So the cohort study was implemented by our 4 national research partners in each of the countries, and we were able to recruit around about 1,600 people into the cohort study, which is an amazing achievement over a short period of time. And you can see we divided the cohort into 2 groups, so people who use drugs and then people who didn't use drugs, and there are some differences between those 2 groups, not in terms of age, but you can see that the people who used drugs who participated in the cohort study were around about 80% of them were males, whereas the people who didn't identify as people who used drugs, only 55% of them were males, and so on. So there were a few differences between the groups, but you know, effectively we were then able to see how things worked within the two groups. But I'm only going to be presenting the total findings today, focusing on those key outcomes I mentioned earlier. So when we interviewed people at 6 months, we saw that around about 34% of people had witnessed an overdose since their baseline interview. And that's kind of along the lines of what we expected when we were planning the study. We had overdose responses there, and 90% of people, so 89%, actually used naloxone at their witnessed overdose. Nearly all of those people survived, and we don't know, the people who might not have survived, we actually don't know. So around about 100% survived, which is pretty amazing. And you can see some of the other findings there. So overall, what this study's shown is that take-home naloxone, along the lines of the SOS project, can be implemented at scale in these countries. It works to improve responses by overdose witnesses, and it also empowers them and can improve the whole situation in which people live. And also, we find that people use naloxone at witnessed overdoses in line with expected targets. So as Dzmitry mentioned, we're doing some further data analysis and dissemination of results. We're supporting sustainability and scaling up. We want to advocate and promote overdose response in other countries and regions. And then we need to ensure widespread dissemination and implementation of the materials. And finally, integrating opioid overdose response into all of these technical packages. As I mentioned, we had an amazing group of national research partners involved. Some of these people are listed here in this slide. I'd also like to particularly acknowledge the WHO and UNODC and all of the people from those two organisations involved, especially Anja and Dzmitry, and also funding, which we know came from INL. Thank you very much.
Great, thank you so much. Really great findings, a lot of work again. If anyone has any questions, we are going to do a discussion at the end. To present on the effectiveness of naloxone in saving lives, I would like to introduce Professor Strang, who is leading clinical academic who has conducted extensive addiction research studies and has worked with governments to improve responses to problems of addiction and related complications based in King's College in the UK. Professor Strang has worked in the addictions field as a clinician and a researcher for 40 years and has had an active interest in working with policy formation. He is head of the Addictions Department at King's College London and has been the director of the National Addiction Centre since 1995 and is highly cited author with over 500 publications. I'm really pleased to introduce Dr. Strang and turn over the floor to you to present. Thank you.
Well, many thanks for the kind introduction, and also many thanks to the previous speakers who covered some hugely important areas. Can I just check, first of all, that you can hear me, and secondly, you can see my title slide?
We can.
Okay, and I've now moved my slide to the second slide. Has that worked?
Yes, it does.
Okay, thanks. So, I'm actually doing a talk that, in a way, tries to pull together some of the hugely interesting and impressive evidence that you've just heard presented from Anja, Dzmitry, and from Paul, talking about the SOS initiative. I'm sort of taking a step back and looking at why is overdose awareness and management and naloxone so important. Within my declarations, just to point out, I've worked with not only providers and policy people, but also pharmaceutical industry to try to develop better forms of various medicines, including naloxone, and some of that's within the slides that I'm presenting. If people are wanting to read more about it, there's a book that various of us put together about drug policy and global public good, which includes sections about take-home naloxone. That's a very good briefing document for those of us involved with policy. And for a deeper dive into the overdose management and naloxone field, EMCDDA in Europe put together a monograph which can be either downloaded or they'll send a copy to you by post. So why is it such an important issue and what are we grappling with? Well, let's just look at the US data. The US has been particularly hard hit. Here we have the prescription opioid overdose deaths over the last 20 years, increasing something like fourfold over the last 20 years. On top of that, on the right-hand side here, we can see the heroin overdose deaths, which over the last 5 years or more have hugely increased. And then the third graph that I've squeezed in here is the last few years where we've seen fentanyl, both prescription diverted fentanyl and illicit fentanyl deaths taking off in a very extreme way. So we have 3 overlapping epidemics of opioid overdose deaths. Looking back to do with our awareness and the need to act, back in 2013, we have this UNODC report drawing global attention to it, which UNODC and WHO put together. And then the following year, WHO convened an expert group to prepare guidelines about the community management of opioid overdose. So this is realizing that in addition to whatever work we're doing at either a policy or a treatment level about helping people overcome their addiction problems, we can also reduce the number of deaths that occur whilst people are still caught up in drug use. And with the specific recommendation that people likely to witness an overdose should have access to both the training and to the naloxone so they can manage it in the interim whilst waiting for services to turn up. It's important that we also realize the need for there to be good evidence-based treatments separate from overdose management itself. So if we look at methadone maintenance treatment, I've just pulled out a single review from Cochrane Reviews looking at methadone maintenance treatment. And here we can see in the bottom list here, overdose mortality massively reduced by people being in treatment. And actually with the dose effect here, that high dose treatment versus low dose treatment, high dose treatment is more protective against overdose. So we mustn't forget these aspects when we're looking at naloxone and overdose management. From part of what science and research have brought to us is a better understanding of when there are times of particular risk. And I'm just going to pull out 3 here. One is during the very first few weeks of somebody starting in methadone treatment, paradoxically, there's a small increase in risk of overdose in those first couple of weeks before somebody gets to the safety beyond that period. As clinicians and as policymakers, we need to be aware of that. We also need to be aware that post-detox or after rehab, people are particularly vulnerable to overdose death if they relapse. So those relapses are more dangerous than the preceding drug use. And then in the middle of my list here is the prison release period. This is a time of a catastrophic coming together of overdose deaths. Looking at this paper from my colleagues, Michael Farrell and John Marsden from a number of years ago now, they looked at people released from prison, looking at when did the deaths occur. And in this next graph here, if I can just explain it to you, on the right, we have the excess mortality for the year after people come out of prison. So how much more likely are they to die than people of their same age in the general community? And on the right-hand side of this graph, we can see that actually they have an increased mortality for a number of reasons, but half of those reasons are in that the sort of the orangey color, and that those are drug-related deaths. But look at the left-hand side. So that's the first week after they come out of prison and the second week after they come out of prison. There's a car crash of deaths. 1 in 200 people coming out of prison with a previous involvement with heroin use, 1 in 200 is dead within a fortnight. So why is there such a special problem with heroin and the opioids? Well, the first point to make is it's not a surprise. The opiates are respiratory depressants. They're used when people have terminal care and have severe coughs to dampen the cough response. They're medicines which actually turn down the respiratory drive. Add to that the fact that someone who's injecting heroin intravenously, you have an intravenous bolus or a slug of this respiratory depressant that is injected in a concentrated form. It's a respiratory depressant. There's a very narrow margin between the dose that gives the effect that's being sought and the dangerous dose. The uncertainty of dose that's being given, and other substances that might be taken at the same time. These all compound the problem. I'll skip the animation because I think it looks as if it isn't working. So let's look at what actually happens after somebody injects heroin. So these are recordings from laboratory sessions we've done with people whilst they are injecting heroin. And they're two extreme examples from the subjects that we were measuring. But on the left-hand side, you can see someone's SpO2. So that's their oxygen saturation, how much oxygen there is in their blood, measured with a simple pulse oximeter. And you can see this man's oxygen levels on the left-hand side. Ordinarily, your oxygen levels will be around 95%, and a default setting might be at 90%, that an alarm would go off that somebody's oxygen levels are dropping to a dangerous level. With this man here, his oxygen levels dropped down to nearly 70%. And then bob back up again. And the dotted line is what happened when we did a second session with the same man. So very worrying picture. And on the right-hand side, we see a similar picture with this woman after she's injected heroin. So we then moved into doing sort of more weird laboratory studies of heroin overdose, where we brought subjects into our clinical research facility, wired them up so that we could measure the expired air that they were breathing out, their oxygen levels, the muscle activity between in their rib cage, and while they were injecting heroin, we could track all of these parameters. So what did we find? Well, let me just guide you through these next 3 slides. So this is the baseline from before this particular individual injected their heroin. We can see at the top somebody's breathing pattern. So over these few minutes that we have captured here, you can see an inhalation in that top line, and then somebody breathing out again, another inhalation, and then they breathe out again. At the bottom, we see somebody's carbon dioxide levels rising and falling. As they breathe out, the carbon dioxide levels go down. And this is what one would expect to see in a normal breathing pattern. And the oxygen levels, the red line in the middle, stay steady and stable at around 95%. So that's a reassuring picture of what you'd expect to see from somebody's breathing pattern. Let's look at this same individual 5 to 10 minutes later, just after they've injected heroin. The top line, you can see these long periods where breathing has completely stopped. and then there's a gasp and somebody starts breathing again, and then it drops down to another period of no breathing at all. And you can see their oxygen levels, the red line in the middle that was previously so steady, has become very disturbed indeed. We were particularly shocked with our studies here to find that even an hour later, so this is the same individual at an hour, whilst it's not as severe as 5–10 minutes later, this is far from normal still, even an hour later. So as a result of that, we need action which is better than to have a local accident and emergency department or even to have an ambulance service. We need the general public, including family and peer drug users themselves, to realize that they are part of the necessary intervention workforce. And the UNODC SOS initiative has already been covered here, but hugely important. And I'd particularly draw attention to the overlapping circles, which Paul Dietze and Anja and Dzmitry have already referred to, of the objectives, the 90-90-90 objectives. These seem laudable objectives, and we must view these as the direction of travel for our work. Now, all of this draws attention to overdose being important, but what are we going to do about it? We need to be able to intervene to reverse that respiratory depression that's occurred. As Paul mentioned, it's now more than 25 years since we first started seriously talking about wider provision of take-home naloxone in the same way as we do for an EpiPen with allergies and with various other interventions that we realize must be placed out there at the point where they're going to be needed, not just reserved for hospitals or for ambulances, like we have with defibrillators in leisure centres and shopping malls or EpiPens. This is our equivalent, that take-home naloxone needs to be out there where the crisis might occur. The key things we need to realize is that it's not just naloxone we're talking about, but teaching people how to manage somebody's respiratory arrest. We need to help with their interim breathing whilst waiting for emergency medical services to turn up. Naloxone is a hugely valuable part of that, but it needs to be in the context of addressing their respiratory arrest. There have been two main strands of how to bring about global attention to take-home naloxone. One has been what, when I used to discuss this with a friend and associate, Dan Bigg, before he sadly died a few years ago, he would see himself as part of an activist movement, a sort of civilian action to assert the legitimacy of take-home naloxone for this population. And my involvement was probably more at the level of how do we make sure that it's incorporated into policy and practice of professionals and planners, that they need to regard that as part of their required practice in the same way as with the EpiPen. In addition to that, we have local action, and we need to also think about national action. And Scotland was prominent in being the first country that embraced the provision of take-home naloxone as a routine standard of care. This is part of what comprehensive healthcare should include when you're looking at how to reduce the burden from drug misuse in society. My last few minutes, I wanted to talk about the development in the last few years of nasal spray naloxone. There were large difficulties, certainly in some communities and countries and in the public debate, with the fact that naloxone was only an injectable drug. And this obviously raised concerns and confusion in the public mind about why were you giving an injectable drug to a population whose problem was often to do with injecting drugs. There wasn't, in my view, any valid concern about the injectable naloxone. It's not a drug that has any abuse potential. In fact, it would be feared by most drug users. But the idea that one could have a nasal spray would make it a great deal easier to introduce into communities, for example, in a prison setting or in a hostel setting, or in countries that wouldn't permit the injectable form. I'm going to give some examples here from some of the work we did early on, looking at what characteristics did we want from a nasal spray to make it comparable to the injection, and then to consider how it might be different. If we look at the blood levels here, and we can think of the blood levels as being broadly comparable to the effect the naloxone would have of displacing the heroin off the receptor in the brain and getting the breathing to restore. After an intravenous injection, which we see in this graph, there's a huge spike, a huge surge of naloxone, and then it comes down to the level where it's still reversing the opioid effect and the respiratory depression. And this is what an intravenous injection would cause. And here in blue, we see what an intramuscular injection would cause. And we can see it's virtually the same as in the intravenous, except it doesn't have that big spike. Now, ambulance crews and accident emergency doctors would often complain about giving intravenous naloxone, not only because it's difficult to give it intravenously, but also because it would often provoke aggression or provoke further drug-seeking behavior. And they often moved to giving it intramuscularly. So it looks as if the spike was causing a problem rather than a benefit. And so the blue intramuscular curve came to be the one that we were wanting to replicate with the nasal spray. And so over the studies, we compared 3 different concentrations. The weaker concentration, the 1 milligram spray, was the lower purple line. The 4 milligram concentration was the green one, and that became what in the US and Canada was the Narcan nasal spray. And the 2 milligram concentration is the red line, is what became the Nixoid nasal spray across Europe and Australia. And more recently, the Norwegian nasal spray is between the red and the purple lines. And we can see they're all giving, well, the commercial ones, that's the close to the red and the green lines, they're giving a speed of onset, that's the left-hand side, broadly comparable to an intramuscular injection, but actually with better blood levels for the subsequent couple of hours. So now around the world, we've got 4 different commercial approved nasal sprays. The most recent one in the bottom left is in a rather cool carry kit. I think this is actually an important issue, and I think the video I'm about to show doesn't, the animation probably isn't working, but the advantage there is it's far more likely to be carried in your pocket, passing what we'd refer to as the Levi's jeans test. You know, if it's not in your jeans and not on your person at the time, it's not going to save somebody's life if it's in a cupboard, back in your home. So the final point is that we need to be careful not to give excessive doses, because this can sometimes provoke either aggression to the people who've helped resuscitate you, or it might provoke further drug seeking to reverse the reversal that's caused a withdrawal syndrome. And that's obviously counterproductive. So in my view, we need to look at how do we teach dose titration. Working with my colleague Joan Neal, we looked at emergency resuscitations that had been managed, and with a significant number where the excessive use of naloxone had caused problems itself. So this is not a reason not to use it, but it's a reason to realize that it needs to be used in a dose appropriate way. The twin pack format of naloxone seems very sensible. It's a crude way of enabling people to do some sort of dose titration, but this needs to be part of the teaching that we do to people, that you need to give enough but only enough to reverse the overdose that's occurred. You don't need to provoke withdrawal symptoms and the complications that that brings. So the summary slides, we've achieved extraordinary acceptability and feasibility from the peer group of drug users themselves, from family members, and from other crucial personnel such as hospital staff and police. The training schemes you've heard of with the SOS scheme, local and national schemes. We need to think locally and think nationally. The UN and WHO recognition has been hugely important, and the arrival of approved nasal spray forms of naloxone makes it a great deal easier to introduce it in settings where it wouldn't previously have been possible. So what do I see as the challenges for the next few years? We need to broaden the provision of the training and also increase the extent to which it's provisioned. So risk awareness, crisis detection, the interim emergency care, and looking after somebody thereafter. The workforce, we need to think more broadly about who those first responders are. We need to improve the products, and that includes their portability. Not just, it's not good enough to give someone a clumpy form of naloxone which they won't have on them. We need better science to study it, and that includes implementation studies such as the SOS initiative that you've heard about. And public policy making, we need to engage with politicians, policymakers, and the general public that this should be part of the routine provision of care. So my overall message is, I think collectively we can be very proud of what we've achieved, but also humble and remind ourselves about how much more we still need to do. Thank you very much.
Great, thank you so much. This was another great presentation, and I know that we've got about probably 10 minutes to go to some questions. I just want to summarize a little bit of our webinar so far. Is that we've noted that there are effective treatments for persons with suffering from substance use disorders, and that recovery is possible. There are effective medical interventions to reverse an overdose from opioids. By using naloxone effectively and continuing to maintain supervision over an individual, we are saving a life so that a person can recover. And there have been many we've seen the science, we've seen the projects, and just looking at how we can really expand this. So I'm really glad that we still have nearly 400 people on this webinar, so thank you. I would like to turn the floor now to questions in the chat, and I want to really try to get to all of them. I want to thank everyone who sent questions, and that we will try to go through them very quickly. I think I found one for each of the presenters, so this will be good. One of the first questions I'll just address quickly is that there was the question about the need to also focus on the supply chain and to go after those that traffic illicit drugs. And I know that many governments, through the Commission of Narcotic Drugs that takes place on an annual basis with the United Nations, addresses the importance of supply reduction, and really varies on the supply reduction issues, varies from interdiction and alternative development to control of chemicals, and those are all very important. The CND, Commission on Narcotic Drugs, also places a great deal of discussion on drug demand reduction efforts, covering the need for prevention, treatment, and recovery. So there are lots of different groups that focus not only on supply reduction issues, but also on drug demand reduction issues. Those are both very important, and you need to have both of those. So for today's webinar, we're really focusing on a very specific aspect of drug demand reduction programming in honor of Overdose Awareness Day. We've had a lot of different questions. Another question I'm going to ask Professor Dietze to kind of comment on. We noted that there was 115,000 persons that died in 2017, and of this number, how many are women? The question was, I mean, how many men compared to women in opioid-related deaths, and approaches to build overdose awareness? So really, we've seen a lot of men and come out in the different studies, but what about women overall?
Look,
Yeah.
So basically, you know, my understanding, I haven't seen that particular statistic, but it's usually somewhere between 60 and 80% of fatalities involve men rather than women. And obviously that's going to vary by country. But one of the great things is, you know, when we do our training, and the SOS training was a really good example, when we do training of health workers and friends and family and so on, women do tend to get more involved, and there is a range of studies showing that. And it is really important to get women as friends, family and carers of people who use opioids involved in opioid overdose response along the lines of the things that John was saying.
Great, thank you so much. The next question I'm going to ask for Dr. Stange to maybe address this one. In Finland, professionals have been against naloxone programs since buprenorphine is our most overdosed opioid, which is also often combined with alcohol and benzodiazepines. What are your opinions on this?
Well, thanks for the question. On the whole, it seems to me that preventing overdose deaths is something that should exist in parallel with other treatments. So whether you're looking at someone who is pursuing a personal plan that is complete abstinence, or whether they're on a maintenance program, with both of those approaches, your objective is that they're not involved with illicit heroin use or fentanyl use or illicit drug use at all. But you're also aware that there's a high likelihood that they will occasionally use, that even if they're now drug-free, there may be an occasional lapse. And you want to make sure that something disastrous doesn't occur when that happens. So it is a little bit like EpiPens for people with severe food allergies. You know, at one level, you could say, well, people should just be more careful and make sure they don't eat those allergens. But you also want to say that in the event that they do, either inadvertently or carelessly take something that causes an allergic reaction, you want to make sure the EpiPen is close to hand. In our field, we're arguing the same principle should approach. So I would see it as something that should exist in parallel with all other types of intervention.
Great, thank you so much for answering that question. The next question, I think maybe either WHO or UNODC, how effective is the education component as far as reducing stigma?
I mean, thank you for the question. And I think, I mean, with a view to our SOS study and the qualitative results that Professor Paul Dietze has presented, in reality did show this. I mean, one of the effective things, how SOS was implemented, is that service providers, sometimes even police, but then also people who use drugs, their families, peers, were trained together. So already kind of this joint training was very useful in building trust, and that came out in the SOS study very strongly in the qualitative data that we collected.
Great.
Maybe just to add additional
anyone else, if you want to answer the question, would be great.
Yeah, it's about the stigma also. That's what we've seen in the qualitative data, that many people speak about the reduction of self-stigma and the feeling of being valued by the fact of having this project, by the fact that somebody really like value lives of people. So I think that's, well, any good support and improvement of treatment is also, like, as a side effect, helps people to get more empowerment and belief in themselves, and also hopefully increase their help seeking, recovery, access, etc.
Great, thank you. And since I have both of you on the screen, could you also answer the question, with 366,000 deaths related to drug use that are not overdoses, why are we not promoting, these types of programs internationally?
Absolutely. I mean, all of these programs should be promoted internationally, right? both looking at deaths directly related to use of drugs or indirectly related to the use of drugs. And both UNODC and WHO, thanks to the support we are receiving from member states, of course, are also working on the indirect causes like hepatitis or HIV prevention and so on. And I think one of the major things we have shared in the international standards for treatment of drug use disorders, and which some of the speakers have mentioned also before, is that of course we need integrated approaches, right? So this program on opioid overdose prevention and management, we see very much, as part of a larger continuum of care. And so would be all the work on preventing indirect kind of deaths, like through HIV or through, hepatitis, tuberculosis, and so on.
Great, thank you. I also have a question, and this is for anybody on the panel. Do you have data or approaches on overdose, excuse me, within the LGBTQ community?
Well, maybe I can start addressing this difficult question, and to say from the beginning that in general the surveillance and health information systems in many countries is not developed enough to properly track overdose and drug-related mortality. And this is also partially due to stigma, because what we've seen also in some of our project countries, that people they hesitate to report overdose. They even ask clinicians not to put it as a diagnosis, as a reason of death, because of potential stigma. And so there's a lot of work to do to improve surveillance, and also to improve surveillance in minority groups. I mean, the previous question about male versus female, we still lack good statistics for many countries. And well, of course, that's one of the area, the improvement in surveillance and monitoring is one of the crucial direction in the field.
Great, thank you. And I'm going to try to squeeze in one last question before we reach our 90 minutes here. And this is also, again, to any of the presenters. What is the role of fentanyl on the international scale in opioid overdoses? This person says we're seeing high levels of overdose with fentanyl and cocaine, methamphetamine, and other pills.
I might start really quickly. So fentanyl is a major game changer. We are very surprised here in Australia that we don't have illicit fentanyl on our streets. So unlike the North American crisis, in spite of the fact that it's much more transportable than heroin and so on, we just aren't seeing it. But what's emerging now is a fentanyl economy. And I think we've all got to be pretty concerned about that, given the relationship that John was pointing out in relation to oxygen saturation and so on, with rapid onset opioids like heroin. When people are seeking out fentanyl, and there's evidence of that in North America now, that people are actually seeking fentanyl as the drug of choice. We need to be getting more and more concerned about the way in which it's going to evolve over the next few years. It's easily produced, and it comes from different sources than we're used to. So some of our anti-trafficking mechanisms, for example, aren't going to work so well in that space. So it's a huge conundrum, I think. And I don't think we have the answers yet. Some of the other speakers might chime in.
No, I think it's
do I have time to do I have time to chip in with a little bit of extra? I mean,
yes.
Yeah, I mean, the international profile of it is strange, as Paul was saying, because in much of Europe we don't have a significant fentanyl problem. There's a couple of countries where it's very different, but for a lot of Europe we haven't seen the North American problem just translate. And you'd have thought in today's environment, communication is such that would happen. So there's obviously other factors that influence how drug use patterns occur. But relevant to today's webinar, I think we've also got to realize that even though fentanyl overdoses are a nastier problem to deal with and will cause us added grief, the actual responses are still broadly the same. You need emergency interim management of the fact that somebody's stopped breathing, and if they don't start breathing again, they're going to die, and naloxone reverses it. So even though if it's been a massive overdose, you may need more of that intervention, the principles remain the same, and hence the SOS work remains valid, even if over time we have to sort of fine tune it and adjust it to a changing situation.
I think it's a great way just to kind of end the whole webinar, is really, you know, just again stating the work that UNODC, WHO, and of course everyone in your work on naloxone. Thank you so much. I want to go ahead and close and thank our panel of experts once again for their time and energy towards addressing opioid overdose awareness. I would also like to note again that beginning tomorrow, the United States will be celebrating an entire month of recovery during September to recognize those in recovery and the importance of sustained recovery from substance use to promote healthier and more productive lives. I would also like to thank our international organization partners that are doing so much, from expanding the recovery workforce through trainings and toolkits, launching recovery certificates, and to ISSUP that hosts a recovery network on this website. If we were not able to get to your question, I know there were many, many questions. I tried to select a good a bunch of them, but there are networks on the ISSUP's website, and it is the Overdose Awareness Network, and the link is in the chat that was just provided. And with that, I would like to end the webinar recording. Thank you so much, everyone.
Thank you. Bye-bye.
Thank you very much. Bye-bye.